Premenstrual Dysphoria and Psychedelic-Assisted Therapy, a call for compassionate use. My name's Tina Williams. I'm an author, writer, analyst, and premenstrual disorder awareness advocate. A little bit about me. I was diagnosed with premenstrual dysphoric disorder, or PMDD, in 2019. Since my diagnosis, I've written 2 books on my personal experiences with premenstrual dysphoric disorder and psilocybin mushrooms. I have a Substack, Menstrual Moods and Mushrooms, where I cover topics related to menstrual cycles, mental health, and psychedelics. So the target audience for this presentation includes PMDD patients seeking resources to self-advocate for psychedelic-assisted treatment options as they become available in traditional medical systems. A couple of places where that's happening now is Canada, Australia, and Oregon in the United States. Also, professionals in the psychedelic space seeking information on premenstrual dysphoric disorder, or PMDD. Quick disclaimer, I'm not a medical professional. I'm an analyst, researcher, writer, and PMDD patient providing information and patient advocacy from a patient's perspective. Psychedelic medicines are not right for everyone. This presentation does not cover risks and harm reduction. If you're considering psychedelic therapy, please do more research and consult with a qualified medical professional before doing so. So, psychedelic-assisted therapy for PMDD, a call for access and compassionate use. PMDD continues to be understudied, possibly in part because of cultural concerns within the medical community. There are no studies on PMDD and psychedelics despite their potential to treat other mood disorders. Current treatment options for PMDD are not right for everyone. Sometimes they have limited efficacy and the only medically recognized cure is highly invasive that includes chemical and surgical menopause. PMDD symptoms have significant overlap with PTSD and major depressive disorder. Psilocybin mushrooms and other classical psychedelics have demonstrated significant therapeutic potential for PTSD and major depressive disorder. So what is PMDD? PMDD is a cyclical mood disorder. It affects an estimated 5 to 8% of females of reproductive age. Symptoms present during the luteal phase of the menstrual cycle and subside within a few days of starting menstruation. So the luteal phase is roughly the 2-week window before starting a period. A brief history of PMDD. An 11th century female gynecologist documented premenstrual symptoms in the diseases of women, quoting, "There are young women who are relieved when the menses are called forth." So this statement speaks to the cyclical nature of symptoms that may be experienced before the period and then are relieved once the period starts. So by the 1950s, these symptoms were referred to as premenstrual syndrome, which covers a wide range of symptoms that females may experience before their periods. So what we know of as PMS would also be included in this premenstrual syndrome. An important distinction between PMDD and PMS is that PMDD is debilitating in nature, where PMS does not necessarily interfere with daily life. By 1987, late luteal dysphoric disorder was included in the appendix of the Diagnostic and Statistical Manual of Mental Health, also known, or mental disorders, also known as the DSM. It wasn't until 2013 when PMDD was added to the DSM with full diagnostic criteria under depressive disorders. In 2019, the World Health Organization added PMDD to the International Statistical Classification of Diseases, otherwise known as the ICD. Quality of life with PMDD. Females experience an estimated 450 menstrual cycles in the modern era. This is really unprecedented in our evolutionary history. Females in the past would have had more children, started having them earlier, and breastfed longer. So, females who experience PMDD symptoms for 1 week per cycle would experience about 8.6 years of symptoms throughout their lifetime. An important point is that the luteal phase is about a 2-week window before the period starts, so some experience symptoms for the entire 2-week window. There are many cultural considerations for PMDD because it is related directly to the menstrual cycle. So in 2014, after PMDD was added to the DSM, a paper titled "Is PMDD Even a Disorder?" was published in the Journal of Bioethical Inquiry. Quote, "This paper argues that PMDD should not be listed in the DSM or ICD at all, adding to the call to recognize PMDD as a socially constructed disorder." And then again in 2022, a paper titled "PMDD, a Controversial New Diagnosis" was published in a global gynecology journal. Quote, "Among the opponents were feminist scholars who saw the label as a way of silencing women and as an inappropriate categorization of aspects of ordinary life as a mental health disorder." So in the following slides, we'll get into what the diagnostic criteria is for PMDD and why this cannot be considered an aspect of ordinary life. Diagnostic criteria for PMDD is similar to other depressive mood disorders and would include at least 5 of the following 11 symptoms and include at least one of the first 4. So you have marked depressed mood, feelings of hopelessness or self-deprecating thoughts, anxiety, tension, feelings of being keyed up or on edge, marked affective lability, persistent and marked anger or irritability or increased interpersonal conflicts, decreased interest in usual activities, sense of difficulty in concentrating, fatigue, lack of energy, change in appetite, overeating or food cravings, hypersomnia or insomnia, a sense of being overwhelmed or out of control, and then other physical symptoms like breast tenderness or swelling, headaches, joint or muscle pain, bloating, or weight gain. So in PMDD, which would be different than PMS, symptoms are severe enough to interfere with daily life, including work, school, relationships, etc. Symptoms must be related to the menstrual cycle and not an exacerbation of another disorder. If there is another underlying disorder and the luteal phase exacerbates that disorder, that would be known as PME, which is different than PMDD. And then in addition to that, you would need at least 2 consecutive symptomatic menstrual cycles. So what causes PMDD? There's a couple of theories. The leading theory is that PMDD is a result of an abnormal response to normal hormonal changes. So normal hormonal changes meaning that there's no evidence to support that PMDD is a hormonal imbalance or that anything is different about the hormones from someone that has PMDD and someone that does not. So in 2017, a study found that gene expression in a large gene complex differed between PMDD patients and controls. The suspect gene complex regulates epigenetic mechanisms that governs the transcription of genes into proteins in response to the environment, which include sex hormones and stressors. So this study was the first to demonstrate that PMDD is a biologically based behavioral abnormality to normal levels of ovarian hormones. For most women, the menstrual cycle does not trigger extreme debilitating mood swings, but in a small percentage of the population, normal levels of sex hormones produces debilitating symptoms. So we're not talking about the general population. What we're referring to is a small subgroup, which would be known as the PMDD phenotype, that is experiencing these symptoms related to the menstrual cycle. So a quote from the 2017 study: in women with PMDD, experimentally turning off estrogen and progesterone eliminated PMDD symptoms, while experimentally adding back the hormones triggered the re-emergence of symptoms. This confirmed that they had a biologically based behavioral sensitivity to the hormones that might be reflected in molecular differences detectable in their cells. So more research is required to better understand PMDD, but based on the current research findings, there's a few key points to consider. It's known that ovarian sex hormones trigger symptoms in PMDD. It's not known that they cause PMDD. Most women do not experience these types of symptoms related to the menstrual cycle. And the suspect gene complex in the NIH study is related to epigenetic mechanisms. So that's an important point because hormones are an epigenetic input, just like other environmental inputs like sound, smell, lights, foods, etc. So given this research, it's possible that ovarian sex hormones are acting as an epigenetic tag that triggers PMDD symptoms. For example, a veteran with PTSD may be triggered by the sound of fireworks. The fireworks didn't cause the PTSD, rather they trigger the symptoms because they are an epigenetic reminder. So trauma experienced during the luteal phase of the menstrual cycle, when these hormones are present, within the family line or within the woman's lifetime, could explain this chronic reemergence of symptoms during this phase of the cycle. So another complementary theory about what may cause PMDD is known as the withdrawal theory. So this addresses the almost instantaneous relief of PMDD symptoms with the onset of menstruation. So during the luteal phase of the cycle, progesterone is released to prepare the body for pregnancy. Allopregnanolone, which is a progesterone metabolite made by the body from progesterone. Allopregnanolone, also known as allo, works on the same receptors as alcohol and benzodiazepines and produces a potent anti-anxiety effect. So interestingly, PMDD symptoms have some overlap with alcohol and benzodiazepine withdrawal, including anxiety, irritability, sensory sensitivity, sleep disturbances, difficulty focusing, etc. An important point here would be the sensory sensitivity. That's not listed in the diagnostic criteria, but it's well known within the community that this is a very commonly experienced symptom. For me personally, during the luteal phase, the sensory sensitivity was heightened. Lights, sounds, people around me, any type of sensory input can be overwhelming for someone suffering from PMDD. So, and a quote on the withdrawal theory from the Massachusetts General Hospital Center for Women's Mental Health. Perhaps this type of immediate relief is akin to substance use disorders and symptoms of withdrawal. It could be that reinstatement of a certain amount of steroids in the follicular phase of the cycle diminishes a withdrawal-like response to these steroids. So what we're speaking to here is the cyclical nature of hormones in the menstrual cycle, with chronic exposure in the modern era, and possibly that a small percentage of women are experiencing a withdrawal and tolerance cycle that would be akin to like an alcohol and benzodiazepine withdrawal. So another quote, chronic exposure to progesterone and aloe and rapid withdrawal from ovarian hormones may play a role in PMDD. There are a couple risk factors for PMDD, but most notably trauma. A history of trauma or PTSD is a known risk factor for developing PMDD. So a study with almost 4,000 female participants demonstrated that trauma and PTSD were independently associated with PMDD and premenstrual symptoms. Another study with almost 1,500 females found that traumatic events greatly increased the odds of developing PMDD. Then in a smaller study, 83% of PMDD patients reported early life trauma. So a quote from the World Psychiatric Association section on women's mental health. Clinicians should be aware that women who present with premenstrual symptoms may also have a history of trauma and PTSD that needs to be addressed. So what's the difference between a PMDD and PTSD diagnosis? There's significant overlap between PMDD and other mood disorders, including PTSD. So the difference between the two in the diagnostic criteria is really more a matter of perspective. For example, a PTSD diagnosis requires an association between symptoms and trauma, where a PMDD diagnosis requires an association between symptoms and the menstrual cycle. In PTSD, the criteria requires that a person was exposed to trauma and re-experiences the traumatic event, where in PMDD, a history of trauma is a known risk factor, but experiencing trauma is not required for the diagnosis. So if we look at the actual diagnostic criteria for PTSD, the way that the questions are worded are from a perspective of experiencing a traumatic event. So the person was exposed to death, threatened death, actual or threatened serious injury, or threatened sexual violence, etc. And then that the traumatic event is persistently re-experienced, and avoidance of trauma-related stimuli after the trauma. In PMDD, these types of questions are not asked. Again, it is a matter of perspective. For PMDD, we are talking about from the perspective of symptoms and the menstrual cycle. That is the association. And in PTSD, the association is from trauma to the symptoms. Now, the overlap between actual what is experienced with PTSD and PMDD is quite similar. So you'll see with PTSD, you have overly negative thoughts and assumptions about oneself or the world, negative affect, difficulty experiencing positive thoughts, positive feelings, decreased interest in activities. The same is true in PMDD. It's just worded a little differently. So you have depressed mood, feelings of hopelessness, self-deprecating thoughts. These negative thought patterns, self-deprecating thoughts is really suicidal ideation would fit in here in the same way that it would fit within PTSD. So in addition to kind of the depressed symptoms, you also have irritability or aggression in PTSD and PMDD, difficulty sleeping, and then you have hypervigilance and heightened startle reaction. The same is true in PMDD, just worded differently. Anxiety, tension, feelings of being keyed up or on edge. So the main difference, again, in PMDD is that the symptoms are related to the menstrual cycle, whereas in PTSD, you would have your symptoms are related to a traumatic event. So, given the overlap between the two, there are certainly women that have PMDD that also would qualify for a PTSD diagnosis and vice versa. You have women that have a PTSD diagnosis that if they were to track their symptoms according to their menstrual cycle, they may also qualify for a PMDD diagnosis. So the kind of overlap between the two of these is pretty substantial. Now, what's the difference between PMDD and major depression? Same kind of thing. The overlap is significant. You have depressed mood, loss of interest or pleasure in activities. Also, interestingly, in major depression and PMDD, you have the weight loss, weight gain, increased appetite, etc. Sleep disturbances, so hypersomnia or insomnia, and then you have the in MDD, a sense of worthlessness or excessive, inappropriate, or delusional guilt. In PMDD, you have depressed mood, feelings of hopelessness, self-deprecating thoughts. So these symptoms have significant overlap, again, with the main distinction being that in PMDD, these symptoms are relieved when the menstrual cycle begins. So, treatment or traditional treatment options for PMDD include the SSRIs, and then therapy, cognitive behavioral therapy, especially, which would also be, if you have someone with PTSD or major depression, that's also a treatment option that would be available to them. In addition to those, in PMDD, you have surgical or chemical menopause, and then also birth control. So, can psychedelic assisted therapy alleviate PMDD? The therapeutic potential of psilocybin mushrooms and other classical psychedelics for mood disorders in general is well established. Given the proper environment, psychedelic experiences can facilitate healing from past traumas. Research with medicinal psychedelics, usually in combination with psychotherapy, have shown encouraging results in treating mood disorders, including PTSD and major depression. Classical psychedelics like psilocybin, LSD, mescaline, etc., have been found to modulate brain networks underlying various psychiatric disorders. Randomized, placebo-controlled trials have found psilocybin-assisted psychotherapy effective at treating depression, including treatment-resistant depression. So in 2014, the FDA designated psilocybin mushrooms as a breakthrough therapy for treatment-resistant depression. So because the therapeutic potential for psychedelics are well established at this point, psychedelic research centers or psychedelic research is ongoing at specialized research centers around the world, including Johns Hopkins, Stanford, Massachusetts General Hospital, Hefter Research Institute, the Center for Psychedelic Therapies and Research, Imperial College London, the UC Berkeley Center for the Science of Psychedelics, the Usona Institute, the Pacific Brain Health Center, Columbia University, and the Icahn School of Medicine at Mount Sinai, among many others. So, research suggests that psilocybin rewires the brain for people with depression. So, um, classical psychedelics include psilocybin mushrooms. There are many different types of psychedelics, but as far as research purposes, psilocybin, there is just a kind of an overwhelming amount of research to dig into. That's also my firsthand experiences is with psilocybin mushrooms and not with the other psychedelics. So that said, I think that there's therapeutic potential and opportunity within other substances, but we'll kind of focus this on psilocybin because of the availability of the research. So, a single dose of psilocybin in mice studies prompted a long-lasting increase in the connections between neurons, and that was a study done at Yale in 2021. A more recent study, fMRI scans, showed the psilocybin treatment reduced connections within brain areas that are tightly connected in depression, including the default mode, salience, and executive networks. The process of regenerating neural connectivity is known as neuroplasticity. Neuroplasticity is the brain's way of rewiring itself, allowing the patient an opportunity to create new patterns more easily. So, with neuroplasticity, kind of one of the theories about mood disorders is the pattern of negative thoughts. And the mechanism for that is believed to be responsible for psilocybin's ability to help with this is the neuroplasticity effect. So, allowing people to create new patterns more easily. So, a quote from Yale's Associate Professor of Psychiatry. We not only saw a 10% increase in the number of neuronal connections, but also they were on average about 10% larger. So the connections were stronger as well. So this is really speaking to the neuroplasticity effects of psilocybin in particular. So psilocybin clinical trials include a wide range of disorders and symptoms, including substance use disorders, anorexia, binge eating, depression, body dysmorphia, chronic pain, fibromyalgia, chronic suicidal ideation, bipolar, anxiety, cluster headaches and migraines, end-of-life anxiety, obsessive compulsive disorder, and phantom limb pain. So with the chronic suicidal ideation, that was the symptom that I was experiencing with PMDD. That was the symptom that prompted me to look at more research. When I went to my doctor and explained, I was experiencing suicidal ideation to an extent to where I was starting to plan out how to do it. And that's the point when I was really seeking care for my mental health. And I think that's unfortunately true for a lot of people is that by the time they go to seek care, they are already in a pretty bad place. So, my doctor offered birth control and SSRIs. I considered the SSRIs, but looking at the side effects, including worsening depression and also suicidal ideation, I didn't have the risk tolerance at that point when you are already planning out how to if you're starting to plan out how to act on suicidal ideation, there's really no you don't have any room for worsening depression. So in that instance, that's when I really started looking into research and said, what are my options? And I found psilocybin research. And for me, I did not have my individual risk analysis between SSRIs and psilocybin was quite clear. So, psychedelic assisted therapy for PMDD, a call for access and compassionate use. PMDD continues to be understudied, possibly in part because of cultural concerns within the medical community. There's really not a lot of debate around whether or not PMDD exists within the community of people that experience it. This is really coming from outside of the community that has firsthand experience with it. Cultural concerns are one thing, but the manner in which the cultural concerns have impacted treatment options for women with this disorder is significant. And it's at least in part a reason why there are little to no studies on this disorder and development of treatment options or development of new treatment options. So to date, there are no studies on PMDD and psychedelics, despite their potential to treat other mood disorders. Current treatment options for PMDD are not right for everyone. They don't always work. And the only medically recognized cure is highly invasive. That includes chemical and surgical menopause. If there are other options available to us in traditional medical systems, we should have a right to try them before being asked to pursue highly invasive procedures like chemical and surgical menopause. So psilocybin mushrooms and other classical psychedelics have demonstrated significant therapeutic potential for PTSD and MDD, and these symptoms have significant overlap with PMDD symptoms. So as psychedelic medicines become accessible through medical systems, it's vital that PMDD patients are not excluded strictly because of diagnosis. PMDD is a uniquely female condition, and patients suffering from it deserve access to treatment options that are available also to PTSD and major depression. The main difference, and arguably the main distinction between PMDD and other mood disorders, is the menstrual cycle. So we have an interesting kind of cultural landscape where the different treatment options are being developed and studied for a wide range of mood disorders, except for the disorder that only affects women. So for additional resources on these topics, I have a new book out, Channel 12, Premenstrual Dysphoria, Psychedelics and Altered States, that's available on Amazon. That speaks to my firsthand experience with PMDD and psilocybin mushrooms. I also have a Substack where I cover topics related to the menstrual cycle, mental health, and psychedelics. That's called Menstrual Moods and Mushrooms. I also do case studies, research, culture, mental health care advancements, etc. My website where you can find more resources like this is womaninthebasement.com. And then to reach me directly, my email is tina@womaninthebasement.com.